Welcome back to the conversation. I'm Nexus, your host. You're listening to the Agent House Conversations. Today we are tackling a topic that sits right on a cultural fault line, ADHD. Specifically, we're asking, is rising diagnosis empowering those with real impairments through effective treatments? Or are we medicalizing normal variation, better addressed by non-drug alternatives? Joining me are two guests, ADHD Diagnosis Supporter, who argues that diagnosis enables crucial support for genuine impairments, ADHD Medicalization Critic, who argues that we are pathologizing normal behaviors and over-relying on medication. Ground rules are simple: civil tone, no personal attacks. If we use acronyms or insider terms, we'll define them in plain language as we go. Let's start with our first segment, framing ADHD. Before we debate whether it is under-recognized or over-medicalized, we need a shared baseline. ADHD, Attention Deficit Hyperactivity Disorder, is a neurodevelopmental disorder characterized by persistent symptoms of inattention, hyperactivity, and/or impulsivity that interfere with functioning or development, as defined in the DSM-5. Quick explainer. The DSM-5 is the Diagnostic and Statistical Manual of Mental Disorders, the rule book clinicians use to diagnose mental health conditions. Today, I want us to hold two ideas at once. People can genuinely suffer real-life impairment, and also the boundary between difference and disorder can be contested. ADHD Diagnosis Supporter, let's start with you. For listeners, what is ADHD in plain English? And critically, what makes it different from everyday distractibility?
Thanks, Nexus. Let's be clear about what this isn't. ADHD is not just being distractible or having a busy brain. Everyone gets bored or restless sometimes. According to the CDC, ADHD is one of the most common neurodevelopmental disorders of childhood, usually first diagnosed in childhood and often lasting into adulthood. But the key difference between a personality trait and a diagnosis is impairment. We aren't looking for quirks. We are looking for a persistent pattern that shows up in multiple settings, like both home and school, and actually stops you from functioning, whether that means failing grades, unsafe driving, or chronic instability in relationships.
That focus on impairment is the textbook definition. But ADHD Medicalization Critic, we know that ADHD symptoms such as inattention and hyperactivity fall on a continuum of normal behavior. Since diagnosis depends on subjective symptom checklists rather than objective biomedical tests, are we drawing the line where it counts?
I'm not trying to erase that impairment. If you can't function, you deserve support. But we have to be honest about the tool we're using to draw that line. ADHD symptoms, such as inattention, hyperactivity, and impulsivity, fall on a continuum of normal behavior. Diagnosis depends on subjective symptom checklists with set thresholds, without objective biomedical tests. Essentially, we are taking universal human traits, like getting distracted or acting on impulse, and deciding that once you hit a certain score on a checklist, it becomes a medical condition. Critics of the medical model argue that ADHD traits are at the extreme end of normal behaviors, rather than a distinct pathological disorder needing medical treatment. My concern is that when we rely on checklists rather than biological markers, we risk turning normal struggles with modern life into a lifelong psychiatric label.
All right, let's zoom in on diagnosis trends, because a lot of today's argument comes down to one question. Are we seeing an awareness win or an overdiagnosis problem? Here's the anchor. CDC's 2022 data show 11.4% of U.S. children aged 3 to 17 years, about 7 million, had ever been diagnosed with ADHD. And per CDC's 2024 MMWR on 2023 data, An estimated 15.5 million U.S. adults had current ADHD diagnoses, with over half receiving that diagnosis in adulthood. Medicalization Critic. When you hear more diagnoses, do you interpret that as more people having ADHD or more people being identified? What's your default assumption?
To be clear, a diagnosis rate is just how many people get labeled, which is different from prevalence, or how many people actually have the biology of the condition. My default assumption is that labels can spread much faster than biology does. We aren't just finding missed cases. We are witnessing a cultural shift where people are actively seeking a medical explanation for modern distress. For context, a 2024 YouGov analysis shows online searches for ADHD increased significantly in 19 out of 20 territories from 2019 to 2023. That surge suggests many people are looking for a name for their struggle. But valid impairment doesn't always equal a lifelong neurodevelopmental disorder.
That search volume is undeniable. But ADHD Diagnosis Supporter, clinical data tells a specific story. New ADHD diagnoses among U.S. adults increased from 2020 to 2023 after a prior downward trend, based on 2025 healthcare claims analysis. Is that catch-up for people missed as kids? Or are we medically labeling stress?
High search volume shows people are looking for answers, but the clinical data suggests this is largely catch-up. To be clear, incidence refers to the rate of new cases over time, and the January 2025 study in Psychiatric Research and Clinical Practice attributes the recent rise in adult diagnoses to increased awareness and destigmatization. This isn't just labeling stress. It is a correction for years of under-recognition where impaired adults were simply told to try harder.
Correction is one story, but let's check the source of that awareness. According to a March 2025 PLOS ONE study, self-diagnosed students consumed more ADHD TikTok content, which was linked to misconceptions like overestimating prevalence. Critic. Does that push you toward trend-driven medicalization?
It's a huge red flag. That study suggests the information environment is reshaping how people interpret their own lives. When you constantly see content framing lost keys or procrastination as a symptom, you naturally lower the bar for what counts as a disorder. And regarding the catch-up argument, we need to be careful with that data. Healthcare claims data are essentially billing records. They show us that doctors are writing the code more often, but they don't prove those patients are undergoing rigorous, multi-hour evaluations. If a patient comes in convinced by social media and the clinician has limited time, the path of least resistance is often to confirm the label rather than challenge it.
Okay, so we've agreed the numbers moved, and we disagree on what that means. Next, I want to ask, what does biology actually say here? Brain differences, genetics, and what we can and can't conclude from them. We're going to separate what's true at a group level from what's useful for one individual. When people say brain scans prove ADHD, they're usually mixing those up. Quick vocab. A meta-analysis pools results from many studies to find a pattern. An effect size describes how big the difference is on average. And fMRI, functional MRI, looks at brain activity while people do tasks. Diagnosis supporters, start us here. What do the best summaries of brain imaging actually show without overselling it?
The honest answer is that we find consistent patterns in large groups, but we don't have a diagnostic test for individuals. Specifically, Enigma meta-analyses 2017-2019 show small ADHD group brain differences, Cohen's d up to 0.21, two overlapping for diagnosis. When we say overlapping, we just mean that a person with ADHD might have a brain scan that looks identical to someone without it. So the biology validates that the condition is real. It's not just bad attitude. But it confirms that diagnosis has to be based on behavior and impairment, not a picture.
That distinction, real in groups, not diagnostic for individuals, is critical. But critic, if the biology is real enough to measure, why does your side argue that focusing on it is medicalizing normal variation?
Because real on average doesn't tell us where to draw the line. Almost every human trait, height, anxiety, aggression, has biological correlates, but we don't call every short person disordered. When we focus heavily on brain differences, we risk implying that the struggle is entirely an internal defect. But if there are no validated neuroimaging or genetic biomarkers for individual ADHD diagnosis, as confirmed by recent reviews, then we are still making a judgment call about behavior in context. My worry is that biology exists becomes a permission slip to stop asking whether the environment, like a rigid classroom or a chaotic workplace, is the real problem.
The internal defect versus environment tension is huge. Let's pivot to what we actually do about it. Medication. Diagnosis Supporter. Short-term data looks strong. Cochrane reviews confirm stimulants like methylphenidate and amphetamines significantly reduce ADHD core symptoms short-term versus placebo, with moderate to large effect sizes. But here's the rub. What about the long-term?
First, acknowledging biology doesn't mean we ignore the environment. We should improve classrooms and support the brain. On the long-term question, the data gets messier because life changes, but combination approaches show clear value. An MTA secondary analysis found 56% of children normalized core symptoms on optimized stimulants alone at 14 months, rising to 68% when combined with intensive behavior therapy. That proves the goal isn't just medicate and forget. It's using medication as a foundation so that skills and behavioral changes can actually work.
Wait, before we accept foundation as the final word, we have to look at durability. Critic, the landmark MTA study's long-term follow-ups beyond 2 years, found that initial stimulant benefits on ADHD symptoms and academic outcomes did not persist compared to other groups. If the advantage washes out, what is the medication actually doing?
It is acting as a short-term symptom manager, not a long-term cure. Think of it like treating a fever. It brings the temperature down so you can function today, but it doesn't necessarily fix the underlying vulnerability or teach you how to navigate the world tomorrow. If the long-term benefit washes out, we have to face a hard reality. We are accepting chronic risks like appetite suppression and sleep disruption for a treatment that may not change the final destination. That uncertainty is exactly why I argue we shouldn't rush to medicate milder cases, where the trade-off between temporary focus and lifelong dependence is much murkier.
Let's do risks versus alternatives without turning it into a team sport. When we say risk, we mean side effects, trade-offs, and opportunity costs. When we say alternatives, we mean non-drug supports, things like exercise routines, sleep work, or therapy. Quick glossary. A randomized trial is when people are assigned by chance to different treatments, so we can compare outcomes fairly. A meta-analysis combines results across multiple studies to estimate the overall effect. I want each of you to stick to 2 claims: your top 2 risks people should take seriously, and your top 2 non-drug options you think actually help in the real world, especially over time. Critics, start us off. Name the top 2 risks you think are under-discussed, and the top 2 alternatives you think are overpromised.
I'll assume you mean alternatives that are undervalued because the evidence for some is surprisingly strong. For risks, my top concern is the fade-out effect. The MTA-RCT's 8-year follow-up, published in 2009, found no significant differences in ADHD symptom persistence or functioning between children initially assigned to medication management versus behavioral therapy. We risk banking everything on a treatment that may not sustain its advantage. I also worry about physical trade-offs, specifically growth suppression in children, which is a real biological cost to weigh. For alternatives that actually work, look at aerobic exercise. Meta-analyses of RCTs show it reduces ADHD symptoms with moderate effect sizes around 0.6 to 0.8, similar to short-term medication effects. And secondly, sleep interventions. Getting sleep hygiene right can stabilize attention without any pharmaceutical downsides.
Those are concrete. Now, Diagnosis Supporter, same structure. Top 2 risks you acknowledge as serious, and top 2 non-drug options you actually recommend when medication isn't the whole answer.
I'm glad you brought up exercise. It is a biological intervention, not just a lifestyle tip. For risks, I take growth seriously. Meta-analyses of cohort studies show long-term stimulant use in children is associated with an average height reduction of 1 to 2 centimeters. That's a real trade-off. And it means we have to monitor growth and nutrition, not just hand out a script. My second risk is sleep disruption. If medication helps you focus at 10 a.m. but destroys your sleep at 10 p.m., you lose ground long-term. For alternatives, sleep support is foundational. A randomized trial and its 12-month follow-up found modest, sustained reductions in ADHD symptoms from brief behavioral sleep interventions like sleep hygiene, with no adverse effects in children with ADHD. My second pick is skills training and environmental scaffolding. Medication can improve attention, but it doesn't teach you how to use a calendar or regulate emotions. You need explicit coaching for that.
It's striking that you both agree on the growth risk and the power of sleep. But critic, here's the reality check. Medication is accessible. A rigorous exercise and sleep protocol requires time, stability, and bandwidth. Does emphasizing alternatives risk leaving the most overwhelmed families with no lifeline?
That is the tragedy we have to fix. We've made the pill the cheapest, fastest option, and made the things that actually build health, sleep, movement, skills, into luxury goods. But relying on the easy option is a false economy if the long-term benefit doesn't hold up. If we truly want to help overwhelmed families, we shouldn't just offer them a biological shortcut. We should be subsidizing the coaching and the structural support that make those durable alternatives possible.
Let's do the path forward part. Not just what ADHD is, but what we do so people can function without getting harmed or dismissed. Quick definitions. Section 504 of the Rehabilitation Act means students with disabilities can be entitled to accommodations like extended test time. And the ADA, Americans with Disabilities Act, requires employers to provide reasonable accommodations, regardless of medication use. The big question for both of you: do we solve this mostly by adapting environments, mostly by treating individuals, or do we need a deliberate mix? Diagnosis Supporter, start us off. If you had $1 to spend, do you put it into changing environments or expanding clinical services?
I would split that dollar, because the ethical answer is both. We absolutely need to adapt environments. Neurodiversity frameworks promote adapting education and workplaces to accommodate natural ADHD variations, beyond just pathologizing them. That means designing schools with less pointless friction and clearer structure so fewer kids feel broken in the first place. But we also have to protect individual rights to support. Under Section 504 of the Rehabilitation Act, students with ADHD who qualify as disabled are entitled to reasonable accommodations like preferential seating and extended test time. That legal protection is crucial because, even in a perfect environment, some people will still be impaired, and they deserve targeted help, not just a nicer room.
The 504 safety net is real. But critic, if the environment changes enough, how much medical treatment do we actually need? And crucially, do you worry that focusing on accommodation rights makes it harder to ask for structural changes for everyone?
I don't think rights block structural change. I think relying on medical labels to trigger those rights is the bottleneck. My path forward is to widen door number 1, universal supports that don't require a diagnosis. Right now, we often force families to get a label just to get basic flexibility, but under the Americans with Disabilities Act, ADA, covered employers must provide reasonable workplace accommodations, such as flexible deadlines and assistive technology, to qualified individuals with ADHD, regardless of medication use. That's the model I want to expand. Practical support based on need, not just a medical identity card. If we make those supports standard, flexible deadlines, clear instructions, sensory-friendly spaces, we reduce the pressure to medicalize normal variation in the first place.
That need not label idea is powerful. But Diagnosis Supporter, let's look at the kids who are struggling now, before the revolution happens. CDC guidelines recommend school-based interventions and parent behavior training alongside medication for school-age children with ADHD. Does your side agree that meds should often be the second step, not the first?
For preschool kids, absolutely. Behavior therapy comes first. But for school-age children, the evidence often supports a both-and approach, rather than forcing kids to fail at therapy before offering help. CDC guidelines recommend school-based interventions and parent behavior training alongside medication for school-age children with ADHD. The key word is alongside. For many kids, medication is the tool that stabilizes their attention enough for the coaching and school supports to actually take hold. If we treat medication only as a last resort, we risk leaving kids struggling for years when a combined approach could have helped them thrive sooner.
This brings us to the end. We've seen that ADHD diagnosis can be a lifeline for support, but also risks medicalizing normal variation if we aren't careful. 2 paths: adapt the world to fit more brains, or treat brains to navigate the world. Which trade-off feels more worth it, and why? I'm Nexus. I'll see you in the next simulation. Good night.